Hello, everyone, and welcome to today's Clinical Explainer. I'm your host, and we have an absolutely fantastic, high-energy session lined up for all you medical students out there. Aaj ke is session mein, we're going to decode those incredibly complex textbook notes on twin pregnancy complications, and we're going to turn them into crystal clear, high-yield facts. Whether you're prepping for your final MBBS exams or grinding hard for NEET PG, this is exactly what you need. We're mixing the best clinical concepts with that classic, conversational Hindenglish style to make sure these concepts stick in your brain forever. Okay, let's dive right into this.
So here is our agenda for today. We'll start with maternal and fetal complications, then move to twin-to-twin transfusion, TTTS staging and management, TAPS and TRAPS sequence, twin growth and monoamniotic risks, and finally, delivery rules and guidelines.
All right, let's jump straight into Section 1, Maternal and Fetal Complications.
Concept समझो, और twin pregnancy isn't just double the joy, it puts a massive hemodynamic load on the mother's body, which is basically working overtime. This brings us to some crucial timings for interventions. Twin pregnancy is a massive risk factor for pregnancy-induced hypertension, or PIH, so we give low-dose aspirin, about 80 to 150 milligrams per day. The ideal time to start? Exactly 12 weeks. Now, if we absolutely have to do fetal reduction in multifetal pregnancies, the drug of choice is an intracardiac KCl injection, and the timing for this is precisely between 10 to 13 weeks. Exam में direct MCQ आएगा यहाँ से. You have to mark these weeks. 12 weeks for aspirin, 10 to 13 weeks for KCl.
Now, what happens if one twin sadly dies in utero? Well, it completely depends on the chorionicity. If it's a dichorionic twin, the surviving twin is generally totally safe. Why? Because they have separate vascular systems. But in a monochorionic pregnancy, it's a completely different story. They share a placenta, which means they have vascular anastomoses. They share a blood supply, so if twin A dies, its blood pressure drops to 0, right? This sudden drop causes the surviving twin B to rapidly bleed out into the dying twin's low-pressure system. This leads to acute hypertension, severe anemia, and often death for the survivor too. Blood literally just flows along the pressure gradient, making monochorionic pregnancies incredibly high risk.
And that hemodynamic sharing brings us perfectly to Section 2, Twin-to-Twin Transfusion Syndrome, or TTTS.
This is arguably the most critical, and honestly the most frequently tested complication in monochorionic twins. TTTS happens because of a deep vascular anastomosis between an artery and a vein, an AV connection. It's most commonly seen in monochorionic diamniotic or MCDA twins. I want you to mentally visualize this. Deep arteriovenous connections within that shared placenta are literally siphoning blood from one baby and pumping it straight into the other. It's a completely unequal sharing of resources.
Let's break down how this builds into the clinical picture. We have the donor twin who is losing blood. Their renal blood flow and GFR absolutely plummet, which leads to severe oligohydramnios and anemia. On the flip side, the recipient twin is getting volume overloaded. Their GFR skyrockets, causing polyhydramnios and polycythemia. Now pay close attention to the MCA-PSV, the peak systolic volume of the middle cerebral artery. The severely anemic donor is going to have a hyperdynamic circulation to compensate, so their PSV is greater than 1.5 multiples of the median. The overloaded recipient has super sluggish blood flow, so their PSV is less than 0.8. You need to memorize these exact numbers. They are classic exam pearls.
Because of this severe imbalance, we get a terrifying phenomenon called the stuck twin. Conceptually, what's happening is the donor twin is so wildly volume depleted that its body aggressively activates the renin-angiotensin-aldosterone system, the RAS pathway, just to maintain some semblance of blood pressure. This extreme vasoconstriction and water retention effort completely shuts down the fetal kidneys. You get oliguria, which turns into anuria, and finally antihydramnios. Literally zero amniotic fluid. The baby becomes physically stuck against the uterine wall by the amniotic membrane.
Okay, moving on to Section 3, TTTS Staging and Management.
Identifying TTTS isn't enough. We need to stage it accurately using the Quintero staging system. The subtle yet absolutely critical difference between Stage 1 and Stage 2 is the bladder. Dono में poly and oligo sequence hai, right? But in Stage 1, the donor twin's bladder is still visible on the ultrasound. In Stage 2, the bladder is not visible because anuria has set in. Stage 3 is when your Doppler abnormalities kick in, like absent or reversed end-diastolic flow. Stage 4 is hydrops fetalis, and Stage 5 is the tragic death of one or both twins. Remember, early on, bladder visibility is your key differentiator.
So once we stage it, how do we treat it? The clinical guideline here is incredibly strict, and it's based entirely on gestational age. If the pregnancy is at or below 28 weeks, the gold standard treatment is fetoscopic laser ablation of the vascular anastomosis. We literally go in with a laser and burn those connecting vessels to separate the circulations. But if the pregnancy is beyond 28 weeks, we shift to conservative management with serial amnioreduction. We drain the excess fluid from the recipient's sac to relieve pressure and prolong the pregnancy as much as possible. 28 weeks is your magic cutoff number here.
All right, let's hit section 4, TAPS and TRAP sequence.
These are two complex monochorionic syndromes that students mix up all the time. Let's clear it up right now. First up, TTTS versus TAPS, which stands for twin anemia polycythemia sequence. We know TTTS involves deep anastomoses and a massive fluid imbalance, that classic polyoligo sequence. But TAPS is different. It's an atypical, milder, and chronic form. It happens via tiny anastomoses, usually less than 1 millimeter. Because the transfusion is so incredibly slow, the fetuses actually have time to hemodynamically compensate. So the crucial differentiating factor? In TAPS, you have normal amniotic fluid despite the anemia and polycythemia. And it can happen spontaneously or even after a laser ablation for TTTS.
Then we have TRAP, twin reversed arterial perfusion. This pathophysiology is fascinating but highly morbid. It features an aberrant arterio-arterial anastomosis. The concept is that a structurally normal pump twin, twin A, is literally pumping its own deoxygenated blood backwards, via the umbilical artery, into twin B. Because twin B is receiving poor quality, deoxygenated blood in reverse, its upper body and heart just completely failed to develop. Twin B effectively becomes an acardiac twin.
The morphological outcomes for this acardiac twin are very clinically distinct. You'll usually see one of two main things: acardiac acephalus, where there is literally no head, but the lower part of the body manages to develop, or acardiac amorphous, which is exactly what it sounds like, an unrecognizably shaped mass of tissue with no developed parts at all. It's a severe structural anomaly entirely driven by that reversed, deoxygenated blood flow.
Let's shift gears now to section 5, twin growth and monoamniotic risks.
We're moving from vascular anastomoses to physical space and growth complications. Look at intrauterine growth restriction, or IUGR. Standard IUGR simply happens because multiple babies are sharing limited space and nutrition, so both fetuses end up small. But selective IUGR is a specific complication of monochorionic twins due to unequal placental sharing. One twin grows completely normally, but the other drops below the 10th percentile. The golden rule you must memorize for exams is the greater than 25% discordance rule. If the weight difference between the two twins is more than 25%, you are dealing with selective IUGR.
Now, what if the twins are monoamniotic, meaning they share the exact same amniotic sac? The risks escalate dramatically here. Because they lack a dividing membrane, they're swimming in the same pool. This makes cord entanglement and the formation of true knots highly dangerous. Any sudden tightening can instantly cut off the blood supply. Because of this totally unpredictable risk, the management protocol is a mandatory C-section at 32 to 34 weeks, no exceptions. Also, keep in mind that conjoint twins are another severe complication specific to late splitting in these monoamniotic pregnancies.
Okay, we've made it to the final section. Section 6, delivery rules and guidelines.
This is where theory meets the labor room, and it is heavily tested in practicals and MCQs. Here are your absolute core rules. Gianrico, these are non-negotiable. First, how do we define the first twin? It's simply the fetus that is closer to the internal os. It comes out first. Second, if you have an interlocking presentation where twin 1 is breech and twin 2 is cephalic, their chins can actually lock together during delivery. This mandates an immediate C-section. Third is the 30-minute rule. The absolute maximum gap between delivering twin 1 and twin 2 is 30 minutes. If you exceed this, immediate C-section for the second baby. And finally, methylergometrin is absolutely contraindicated after delivering the first twin. It causes severe uterine contractions and will asphyxiate the second baby still inside. Do not forget that.
So, how does the presentation of the twins dictate our actual mode of delivery? If it's vertex-vertex, both can be delivered vaginally, which is great. If it's vertex-breech, twin 1 is vaginal and twin 2 is an assisted breech delivery. But things get tricky if the presentation is vertex-transverse. In this case, you deliver the first twin vaginally, then immediately shift the mother to the OT for an internal podolic version, followed by a breech extraction. You see, the presentation of the second twin is the absolute key decider here.
Let's talk about how we actually perform that internal podolic version. Imagine you're the surgeon in the OT right now. The indication is that the second twin is in a transverse lie. But note, this is completely contraindicated if the mother has a previous C-section scar, because the uterus might literally rupture. Step 2, you administer general anesthesia to completely relax the uterus. Step 3, you insert your hand directly into the uterine cavity. Step 4, you find and grasp the feet of the baby, gently pulling and rotating them down to convert the baby into a breech presentation for extraction. It's a classic, life-saving obstetrician maneuver.
We've covered a massive amount of high-yield ground today, from TTTS and TRAP to the strict 30-minute delivery rule. But I want to leave you with this final thought. Knowing how deeply chorionicity and amnionicity dictate literally everything, from life-threatening vascular complications all the way to the exact mode of delivery, how crucial is that early first trimester ultrasound? Right? It's not just some routine scan. It fundamentally changes the entire trajectory of how we manage these high-risk pregnancies. Keep that clinical perspective in mind. Keep reviewing your notes, and you're going to absolutely crush your exams. Thanks for joining me for this explainer today, and keep learning.